All right. Thank you to the organizers for inviting me to speak today. My name is Dr. Goldberg. I'm a dermatologist and dermatopathologist by training and medical director at Castle Biosciences. Today I'll be speaking about using molecular diagnostics to inform a range of cancer management decisions for patients with invasive cutaneous melanoma, squamous cell carcinoma, and then in gastroenterology for patients with Barrett's esophagus. Here are my disclaimers and relevant disclosures. So at Castle, as a leading diagnostics company, we aim to provide innovative solutions to disease states with a high unmet clinical need, leveraging new technologies to bring advanced decision-making capabilities to clinicians faced with challenging questions at the bedside for patients with a range of diseases in different therapeutic areas. So this begins in the process of identifying areas of high unmet clinical need, places where physicians currently have questions that they face for patients with impactful disease states in oncology and other types of disease areas. We then bring our testing platforms, whether it's gene expression profiling, next generation sequencing, and spatial biology, to design and deliver tests to clinicians faced with these questions to inform relevant decisions that they face treating these patients in these different disease states. And so today I'll be speaking about two therapeutic areas where Castle Biosciences has tests in the dermatology space and gastroenterology space, specifically talking about our prognostic assays for DecisionDx-Melanoma for cutaneous melanoma, DecisionDx-SCC for cutaneous squamous cell carcinoma, and TissueCypher for patients with Barrett's esophagus. We also have tests in uveal melanoma and in the areas of mental health that I won't be touching on for this discussion today. So first, talking about DecisionDx-Melanoma in cutaneous melanoma, okay? There are traditional approaches to staging that look at the histopathologic features of a melanoma that aim to risk stratify patients based on the presence or absence of particular features in the synoptic report. However, even though we have these validated staging criteria, we actually end up missing patients who have aggressive disease, who are diagnosed with early stage cancer at their initial diagnosis, who go on to sustain poor outcomes from their disease state. So concerning pigmented lesions are a common reason why people present to the dermatologist, and most patients who are diagnosed with cutaneous melanoma actually present at the time of diagnosis with early stage disease, stage 1 and stage 2 cancer. However, if you look at who actually dies from melanoma, excluding patients who present with metastatic disease, most of the deaths occur in patients who were initially presenting with stage 1 and 2 disease. And there's also evidence that patients who are identified at an earlier time point for their recurrences or distant metastases sustain better outcomes than patients who have those metastases identified symptomatically. And so the ability to identify patients at an earlier time point in their disease process, to identify those who are actually going to go on to sustain recurrences, metastases, or die from their disease, presents significant benefits to treating clinicians to inform important decision points. So DecisionDx-Melanoma is a gene expression profile test that, through retrospective, prospective studies, and meta-analyses, have demonstrated the independent prognostic value of this gene expression profile test that looks at 31 genes from the formalin-fixed paraffin-embedded sample that's used to establish the diagnosis of melanoma. RNA is extracted from the samples, a validated algorithm is applied, and 4 class results are returned to a patient, one of 4. Class 1A, lowest risk, Class 1B or 2A, an increased risk, and Class 2B, the highest risk. And this has been shown to be an independent predictor of poor outcomes, specifically relapse, distant metastasis, and death. Seen here in this table, even when looking at the thickness, the breast flow thickness, or depth of invasion, ulceration status, the gene expression profile result is an independent predictor of relapse and distant metastasis in this largest meta-analysis study published in 2020. On the right, you can see the Kaplan-Meier curves that when you're looking at the risk stratification potential of DecisionDx-Melanoma, the top line in dark blue are patients with a Class 1A score are significantly different in terms of their rates of relapse and distant metastasis than the patients in dark orange in Class 2B. And so because this is an independent prognostic factor, you can improve the accuracy of risk prediction when you use the DecisionDx-Melanoma GEP result in the setting of the patient's tumor. And so more recently, over the last 2 years, Castle has worked to provide not only the DecisionDx-Melanoma class score, one of those 4 validated results, but has also designed an integrated test report that looks at the factors that the pathologist identifies under the microscope and that the clinician sees in the clinic to produce a precise risk prediction for two key decision points based on not only the gene expression, but also the breast lobe thickness, ulceration, and mitotic rate reported on each cancer. And using a validated algorithm, these can actually produce precise risk predictions to inform the decisions around sentinel lymph node biopsy, so a precise risk of sentinel node positivity, and also risk of recurrence. So how likely is a patient to experience relapse, metastasis, or death? And these are then returned in reports to the treating clinician in a timely fashion within 3 to 4 business days after submitting the sample. So real-time decision-making can be impacted for these range of decision points that are important for patients who are diagnosed with invasive cutaneous melanoma. This slide is not projecting entirely well here at the top, but there is a recent collaboration that's been started with Castle Biosciences and the National Cancer Institute, the NCI, looking at patients who, through the course of their routine clinical care, received the DecisionDx-Melanoma test and were also in the NCI's cancer registry held at SEER. And so what we find is that patients in this cohort with Class 1A results had significantly different mortality than patients with Class 2B results. Specifically, their melanoma-specific survival and overall survival was improved compared to those patients who had a Class 2B result. And this is a prospectively tested group of patients through the course of their clinical care had DecisionDx-Melanoma, and you see the same risk stratification that has been published in previous studies. We're excited about this result seen in the NCI SEER database. Taking this a step further, we've done a matching exercise, as has been done in other cancer types, again using the SEER Cancer Registry, looking at matched patients tested compared to untested patients. And you find that those patients who received the DecisionDx-Melanoma test as part of their clinical care had improved outcomes compared to those patients who were not tested. This was a similar result seen to another gene expression profile test in breast cancer, the Oncotype DX breast test, that also showed a mortality benefit. Here, looking at DecisionDx-Melanoma, we see twice the absolute mortality benefit for patients who had the DecisionDx-Melanoma test compared to those who didn't in the SEER Cancer Registry, looking at matched cohorts, showing direct evidence of association of improved survival in patients who had DecisionDx-Melanoma test compared to those who did not through the course of their routine clinical care. Changing gears slightly to cutaneous squamous cell carcinoma, talking a bit about DecisionDx-SCC. So I've just focused on melanoma, an impactful skin cancer, and oftentimes keratinocyte carcinomas, of which squamous cell carcinoma is one, are often not appreciated for their impact on morbidity and mortality in patients with skin cancer presenting to the clinic. And based on the prevalence, we actually anticipate that deaths from squamous cell carcinoma will outpace those of melanoma in the United States. And the staging approaches that we use for cutaneous squamous cell carcinoma, whether that's Brigham and Women's or AJCC version 8, actually miss a significant portion of patients who go on to experience metastasis, either nodal metastasis or distant metastasis. We estimate some 30% of patients are identified as having early stage disease who go on to experience these poor outcomes. And so DecisionDx-SCC was developed for patients with one or more clinical or pathologic risk factors, so who have high-risk squamous cell carcinoma, again looking at a gene expression profile sampled from the formalin-fixed paraffin-embedded sample, applies a validated algorithm to produce 3 different classes: Class 1, a low biological risk; Class 2A, moderate biological risk; and Class 2B, the highest biological risk, that can be interpreted in the context of the known clinical pathologic risk factors. Here's a Kaplan-Meier curve from the largest retrospective study to date from 2021, looking at 420 patients who had a high risk of metastasis in this cohort. And even within a group of patients with a high risk of metastasis, the DecisionDx-SCC test can produce 3 independent groups of risk within this group. So Class 1 had about half of the risk of metastasis as the entire cohort, and Class 2B had over 50% of the risk of metastasis in patients with that class score, suggesting that within a group of patients who have a significant risk of a poor prognosis, you can actually independently risk stratify these patients, with about half of the patients having a Class 1 score and half having a Class 2A or Class 2B. I want to use this case example to highlight the limits of what we know in the clinic when confronting a patient looking only at their clinical and pathologic factors. These 2 gentlemen are from the initial validation study. They have similar ages, they have similar tumors on the left temple, both similar sizes, below the 2 centimeters that are often the cutoff for having a large squamous cell carcinoma. Both are poorly differentiated under the microscope, which is a known risk factor for poor prognosis. But our staging system identifies both tumors as being nearly identical, T1 by AJCC or T2A by Brigham and Women's. And those are both early stages in either of those schema. And they look identical. It's difficult to know which of these patients is likely to have a poor prognosis, and yet the DecisionDx-SCC test can identify differences in their gene expression for these 2 different tumors. Patient on the left with a Class 1 score, the lowest risk score, went on to have no evidence of disease over the course of study, And in contrast, the patient on the right went on to experience recurrence, metastasis, and passed from the disease. And so again, I think this presents the clinical challenge facing clinicians working with patients with tumors like this, and the challenges and risk stratification to inform relevant decisions such as how quickly should this patient be seen back in clinic, referral to multidisciplinary clinics, adjuvant radiation therapy decisions that are based on our crude clinical and pathologic systems alone, and that can be enhanced in terms of their prognostic accuracy with gene expression profiling. Changing gears again, the last topic here in gastroenterology, and specifically the TissueCypher test for patients with Barrett's esophagus. So switching gears again, there's an unmet clinical need in the field of gastroenterology around the detection of esophageal adenocarcinoma, and the precursor lesion, the precancerous lesion for this disease state, the only known precursor for esophageal adenocarcinoma is Barrett's esophagus. Currently, we risk stratify these patients based on the presence or absence of dysplasia under the microscope. That's an interpretation done by the diagnosing pathologist. However, the incidence and progression of esophageal adenocarcinoma is on the rise and is a cause of significant morbidity and mortality for patients with GI tumors. One of the challenges with Barrett's esophagus is how do we bring the right intensity of treatment to the patients at greatest risk of progression? And the goal of this pursuit is to identify patients who have a high risk of progression to high-grade dysplasia or esophageal adenocarcinoma at an earlier time point when interventions are possible. And in the same way, triage patients out of intense management who have a low risk of progression to high-grade dysplasia or cancer. And so the TissueCypher test is based on spatial biology, looking at relevant biomarkers, this is protein-based biomarkers, to risk stratify or improve the accuracy of risk prediction for patients diagnosed with Barrett's esophagus. And so the TissueCypher platform looks at 9 relevant protein biomarkers, seen here on the right with the immunofluorescence labels. They include markers such as P53, P16, and others. It converts these images into high-dimensional data elements that an AI classifier then evaluates using a validated algorithm to produce a risk score, low risk, intermediate risk, or high risk, that provides independent prognostic information to improve the accuracy of risk stratification for patients with Barrett's esophagus. So what does this do in practice for clinicians who are faced with which patients to bring intense interventions and which patients to de-escalate for care? And the bars here in the center of this slide demonstrate the information that we have today. This is the diagnosis of Barrett's esophagus with an assessment from the interpreting pathologist about the presence or absence of dysplasia. So they'll identify no dysplasia seen, indefinite for dysplasia, or low-grade dysplasia with associated rates of progression to high-grade dysplasia or cancer. However, by layering the TissueCypher risk score, you can identify patients at greater or lower risk of progression. Seen here in the light blue, non-dysplastic Barrett's esophagus patients with a low-risk TissueCypher score have a strikingly decreased risk of progression compared to non-dysplastic patients with a high TissueCypher score with a much greater than would be anticipated risk of progression. And so this ability to identify patients at differential risk for progression to high-grade dysplasia or esophageal adenocarcinoma can inform important decision points in the clinic, specifically around endoscopic eradication therapy and frequency of follow-up. And so what you can find is that for patients who have Barrett's esophagus with non-dysplastic, indefinite for dysplasia, or low-grade dysplasia, you can use the TissueCypher risk score to inform your approach in the clinic and identify those that may benefit from more intense surveillance or interventions, and in the same way, avoid unnecessary repeat yearly endoscopies, as is so often seen in the GI clinic, and extend to guideline-approved intervals of 3 to 5 years for patients who have no evidence of dysplasia and also a low-risk score by the spatial biology test of TissueCypher. So I appreciate your attention here today, talking about some of the tests that Castle Biosciences offers in the fields of dermatology and gastroenterology. Don't have time to talk about the other platforms that we have and other types of tests that we have, but I'd be happy to field questions afterward, follow-up conversations. And again, I really appreciate your attention and invitation to speak here today.